Good afternoon, everyone. We're going to go ahead and get started. Thank you for joining us today. We welcome you to the Professional Satisfaction and Practice Sustainability webinar series. Before we begin, we wanted to quickly review some housekeeping items. The session will be recorded and will be available after the event. If you have any questions, please place them in the Q&A or the chat box. We will have time at the end of the webinar to answer many, if not all, of your questions. Without further ado, let's go ahead and get started with today's webinar. Today's speakers are Kim Horvath, who is a senior legislative attorney in the Advocacy Resource Center at the American Medical Association, and Sandy Marks, who is the Senior Assistant Director of Federal Affairs, also at the American Medical Association. Today, Sandy and Kim will be presenting on telehealth policy and coverage during COVID-19 and beyond. Welcome, Sandy and Kim. It's a pleasure to have you here with us today. I'm going to go ahead and hand it over to you.
Great, thanks so much. It's a pleasure to be here, and thank you for the invitation. And hello to everyone out there. Sandy and I will talk, the next slide, please. Wanted to start the conversation today with just talking about the value of telehealth, and we'll be talking about this really throughout the conversation today, but thought it was a good place to start. As all of you know, telehealth has really been instrumental over the past 10 months in allowing patients to continue to access care safely while minimizing contact, but also allowing physicians obviously to provide care to their patients while maintaining and adhering to stay-at-home orders. And it's really been given physicians the ability to, in many cases, keep their practices open and be able to maintain their staff. And in some cases, many practices shifted entirely to telehealth early on in the pandemic. And this was really done in short order, and it's been embraced by both patients and physicians. And we'll talk a little bit about that later. Excuse me, you saw a huge uptick in telehealth claims in March and then really peaking in April. There's been a slight decline, but you continue to see a widespread use, generally speaking, on telehealth. And I think it's important to recognize that this exponential growth in success in telehealth over this period would not have been possible without regulators and lawmakers at the state and federal level from rising to the challenge and implementing policies to ensure coverage and payment of telehealth and patient access to telehealth was available. I can speak to the state level, there were many states that had good laws already in place, states like Delaware and Georgia and Virginia, but many states lagged behind. And we'll talk about this in a few, but if not for kind of the quick and swift action by governors and state regulators, we wouldn't have seen the success that we did. But we're at a unique place right now to talk about what's next. And part of this discussion is recognizing the ongoing value of telehealth to address longstanding health inequities. And I think it's important to recognize that the expansion of telehealth absolutely did expose some inequities, such as access to technology, broadband access, and digital literacy. But telehealth, we do believe, can also improve health equity by promoting rural access to specialists that might not otherwise be available in the rural areas. By providing flexibility and convenience for patients, eliminating long trips to the doctor, whether it's just a 2-hour or 1-hour trips in some rural areas to multiple train or bus rides in urban areas. To eliminate the ability or the patients from having to take time off work and letting them see their physician via telehealth, to really giving the patients the ability to maybe have family members present that otherwise would not be available to go to their doctor visits. We also believe that we'll see reduction in ER visits with the continued use of high quality telehealth and improved care for chronic conditions. And all of this really brings us to an understanding that integrating high quality telehealth into physician practices is just one of the tools in the physician's toolkit. And it's imperative in improving the overall quality of care. But to better understand where we go from here, it's probably a good idea to start by looking at where we've been over the past couple months that got us to where we are today and talk about what's next. And I'll kick it over to Sandy. Next slide, please.
Thank you, Kim. Well, the rapid and even exponential adoption of telehealth that began last March pretty much overnight was truly amazing. And I think it really showed all of us in a dramatic fashion how quickly medicine can implement innovations when payers and policymakers break down the barriers that prevented these changes from taking place for decades. On the federal side, HHS and CMS were actually incredible partners. They quickly adopted the recommendations that we made, and they sought us out and asked us what physicians needed to be able to continue to take care of their patients. So we've divided today's webinar into 3 sections. First, we're going to review the telehealth policies that the Medicare program and the states adopted during the pandemic. Then we're going to talk about the direction that these policies seem to be taking so far for the period of time that's going to follow the pandemic. And we'll conclude with some of the telehealth challenges that need to be addressed for the future. Next slide, please. In the Medicare program, this all really began March 6th with the enactment of the Coronavirus Appropriations Bill. And that bill gave the HHS secretary the authority to waive some key restrictions that had been present in Medicare telehealth coverage for many years if 2 conditions were met. The president had to declare an emergency under the Stafford Act, and Secretary Azar needed to declare a public health emergency. Well, the HHS secretary had already actually declared the COVID emergency since January 27th of last year. It's been renewed every 90 days. Most recently, the most recent declaration will be effective next week on January 21st for 90 days following that. And a week after this law was passed, the president declared a COVID emergency under the Stafford Act. So with those 2 conditions being met, CMS was able to start waiving the geographic and originating site restrictions that had existed under Medicare. Next slide, please. This is what meant that during the public health emergency, physicians can provide telehealth to Medicare patients all over the country, not just in rural areas. It also was what made it possible for patients to begin receiving telehealth services in their homes and not have to go to a medical facility in order to get telehealth services from a distant site. A little bit later, CMS increased the Medicare payment rates for telehealth services to equal the in-person office rates. Previously, telehealth services were paid about 30% less than in-office rates. They also allowed telehealth and remote physiologic monitoring services to start being covered for both new and established patients. And they said that RPM services could be covered for both acute and chronic conditions, acute including COVID, for example. Next slide. They also lifted the frequency limits that had previously existed on telehealth services for nursing facility patients and for hospital patients. In addition, that March law allowed any equipment with 2-way real-time interactive communication to be used for telehealth, and this is what enabled the use of smartphones. In addition, HHS waived HIPAA enforcement, so commonly used apps could be used on smartphones for telehealth, like FaceTime. And they changed Medicare diabetes prevention program services, so these were able to be provided virtually, and they relaxed the limits on the once per lifetime availability of those services. At AMA, we heard from many physicians and medical societies in the spring that allowing smartphones and apps was just not enough. They had patients with no internet connection in their home and patients who did have the technology they needed but didn't know how to use it. They needed to be able to provide audio-only visits, not just audio-video telehealth. And CMS fortunately listened. They changed the 3 CPT codes for telephone evaluation and management services from non-covered to active and made them available for both new and established patients. Later, they increased the payments for these 3 CPT codes to be equivalent to the payment rates for in-person established patient office visit codes. Next slide. CMS also added many services to the list of services that Medicare covers when they're delivered via telehealth. They started covering emergency department visits, observation care, critical care visits, ventilator management, and even components of services. So for example, they started covering the face-to-face visits that are part of weekly radiation treatment management, even though no one actually gets radiation treatment in their home. But they were able to provide those weekly check-in services via telehealth. Next slide. This same action by the HHS secretary in declaring a public health emergency that allowed Medicare to expand its coverage so much also allowed the Drug Enforcement Administration to relax its policies on telehealth as it pertains to controlled substances. So controlled substance prescriptions now can be based on a telehealth visit, including an audio-only telephone visit. Physicians who have an X waiver to prescribe buprenorphine for the treatment of opioid use disorder can initiate or continue that treatment based on telehealth or phone visits. OTPs can initiate both new patients and treat existing patients on buprenorphine using either telehealth or audio-only phone visits. And they can treat existing patients who are on methadone via telehealth or phone. For patients on methadone, they can provide those who are stable with take-home medication for the first time. And alternate satellite locations, such as temporary surge hospitals, don't need to apply for their own DEA number. Next slide. Kim? You're on mute.
You were so interesting, Sandy. I was just enthralled. So at the state level, we've been working on telehealth for a number of years, but obviously with a renewed sense of urgency and interest when the pandemic hit. Based on our previous work, we were well positioned to really help states right out of the gate in March, and we provided a series of policy options to the states, including policies that would promote access, coverage, and payment of telehealth, all of which were imperative to ensure patients continue to have access to their trusted physician during the pandemic. Next slide, please. Oh no, I'm sorry, same slide. In response to COVID, all 50 states took some action related to telehealth. And this was really remarkable, especially when you realize that back in March when COVID hit, many state legislatures had already adjourned for the year or were abruptly shut down. By mid-March, there were only 9 states and DC in session. 18 states had already adjourned, and 23 states plus DC and Guam, or plus Guam and the US Virgin Islands, had either adjourned, postponed, or suspended their session because of COVID. So much of the action really fell to governors and state regulatory bodies, and they acted very swiftly. One thing to remember is that governors in most states, but not all states, have the authority to amend or modify existing state law during a declared emergency through an executive order. Since most states had telehealth laws in place already, governors were able to act pretty swiftly. But where governors did not have this authority, they often included language in executive orders encouraging the insurance commissioner to act and or giving, or the insurance regulators took action on their own, typically through insurance directives aimed at private payers or state regulated plans. And then finally, the Medicaid programs issued updates to their plans, expanding coverage through regulations or Medicaid bulletins. CMS gives broad authority to the Medicaid plans to provide coverage and payment of telehealth for telehealth. And in many cases, they don't need to get a separate state plan amendment to do so. And then finally, I'll say that many states took all three of these actions: the governors through executive order, insurance regulatory actions, and Medicaid action. Next slide, please. A couple areas where we saw some of the biggest changes were mostly along the lines of expanding coverage, especially within the Medicaid program, where we saw about 48 states expand coverage of telehealth during that time. They did things, by example, by eliminating originating site restrictions, which limited telehealth coverage to certain sites, such as, which often didn't include a patient's home. They eliminated restrictions on the type of care that can be provided via telehealth. Many state Medicaid plans had not provided telehealth services for mental health. So they eliminated those restrictions. And another thing that was common was eliminating restrictions that only allowed coverage if a patient was a certain distance away from a provider. So eliminating those restrictions. Many states also expanded telehealth coverage for private insurers or state regulated plans as well. Prior to the pandemic, 30 states had coverage parity laws in place, and we saw about a half a dozen states extend coverage parity for private payers during the pandemic. And this was really imperative in making sure that plans had covered services that were provided in person were also covered via telehealth. Along the same lines of coverage parity, we also saw lots of states require insurers and or Medicaid plans to pay for telehealth at the same rate as in-person services. And then the other biggest change that we saw all around was expanding the acceptable modalities. Similar to what the Medicare program did, we saw a lot of state insurers and or Medicaid plans include audio only in their definition of telehealth. About half the states made this change for private payers, and about 30 Medicaid programs did. Finally, a number of states also included language to make sure that patients continue to have access to the same physicians that were able to provide in-person care to also provide care via telehealth, eliminating separate networks of just telehealth providers that were really focused on these kind of direct consumer telehealth companies. This was imperative in making sure that patients continued to have continuity of care with their regular in-person physician. So where do we go from here? Next slide, please. There's widespread agreement really that telehealth is here to stay. Based on some recent surveys, patients and physicians have had overwhelmingly positive experiences with telehealth. According to a telehealth satisfaction survey conducted by J.D. Power and Associates, the overall customer satisfaction score for telehealth was among the highest of all healthcare, insurance, and financial services industries they studied. A survey of physicians and other healthcare professionals by the COVID-19 Healthcare Coalition, which was led by MITRE and Mayo, and the AMA was also involved as well, found similar positive findings, as you can see here, with 68% of physicians reporting that they are motivated to increase telehealth use in their practices. 60% reported that telehealth has improved the health of their patients. And more than 80% said telehealth improved the timeliness of care for their patients, and that patients reacted favorably to using telehealth. So definitely something that people are interested in keeping an eye on. Next slide, please. When looking at potential barriers or future challenges in continuing the advancement of telehealth, physicians are overwhelmingly noted a concern for no or low reimbursement for telehealth post-COVID. Noting that that would be a major challenge for them moving forward. And we have to keep this in mind when we think about the policy that we talk about moving forward. Other challenges really point to the digital divide, including lack of access to the technology to provide telehealth and or internet or broadband access, and a low digital literacy. I'll note too that the ability to be able to practice across state lines has also been identified as a challenge at the state level to advancing telehealth. I will say that some of the research that I've seen on this hasn't necessarily borne this out. For example, the COVID-19 Healthcare Coalition survey, it was a low number of respondents that identified licensure as a barrier. This could be because waivers have been in place in many states, allowing physicians to practice across state lines during the pandemic. So it's just possible that physicians aren't aware of these barriers at this time, but it is definitely on our radar. Next slide, please. Sandy?
Thanks, Kim. Well, CMS issued a ton of COVID regulations, several of which address telehealth policies. They put out interim final rules all last spring, and then this summer's Medicare physician payment proposed rule. In the final rule that was published in the Federal Register on December 28th, they outlined an initial set of telehealth policies for after the public health emergency ends. Unfortunately, CMS does not believe it has the authority to extend the waivers of the geographic and originating site beyond the COVID-19 PHE. The current declaration goes into late April of 2021, and it could be extended for additional 90-day periods. But AMA and other stakeholders are going to need to work with the new Congress to seek permanent changes to these restrictions. The AMA has also been advocating for this with the Biden-Harris transition teams. This is critically important. What's at stake is the continued delivery, the continued ability to deliver telehealth throughout the country and not have it going back to being just available in rural areas for Medicare patients, and the continued ability to deliver telehealth services to patients in their homes. In this final rule, CMS also made a number of additions to its permanent coverage of telehealth services. So group psychotherapy, certain home visit services, cognitive assessment and care planning services, and psychological and neuropsychological testing will be able to be covered permanently as telehealth services under Medicare. Next slide, please. There's also many services that have been finalized to remain on the Medicare telehealth list on an interim basis. So 74 services that were added during the public health emergency for telehealth coverage will end at the end of that public health emergency. But 82 services are going to be on the telehealth list at least through the end of 2021. These services are in a new category 3. The AMA had actually recommended that CMS continue to cover these services via telehealth longer than the year in which the public health emergency ends. And they indicated that potential further extension of the coverage is possible in future rulemaking. The category 3 services with this interim coverage include the higher level home visit codes, all 5 emergency department visit codes, critical care, as well as monthly end-stage renal disease care, hospital and nursing facility discharge management, and a large number of therapy services. CMS also outlined a number of telehealth policies in this final rule, in addition to expanding its list of covered services. Telehealth rules will not apply when the patient and their physician are in the same location, even if technology is used to assist in furnishing a service. So if a physician is on one floor of a building and the patient is on a different floor, and they're using the same technology they would use for telehealth in order to communicate with the patient, that's not a telehealth service because they're essentially at the same location and the same address. CMS also finalized its proposal to allow direct supervision to continue to be provided via telehealth through the end of this year or longer if the PHE goes on longer than this year. And nursing facility visits in the future will be able to be provided once every 14 days via telehealth instead of once every 30 days as it was before the public health emergency. CMS has also clarified that permanently the definition of multimedia communications equipment that can be used for telehealth, just to keep it simple, will include smartphones. So those won't be X'd out after the emergency, although once HIPAA requirements begin to be enforced again, there's not necessarily the same access to those apps and stuff that people have been using on their smartphones. CMS does recognize that it's important to have longer audio-only services available than what it previously covered before COVID, but it does not believe at this time that it has the statutory authority to continue covering the 3 CPT codes for telephone visits once the public health emergency ends. So the final rule is seeking comments for the next 60 days on the addition of a second G code, G2252, which will cover what CMS refers to as virtual check-ins of 11 to 20 minutes. Now, CMS states that this new code will be for patients who may be reluctant to return to in-person visits and allow CMS to consider whether the policy should be adopted on a permanent basis. They also said that the service will not be a substitute for an in-person visit, but rather to be used as an assessment to determine the need for an in-person visit. So we'll be commenting on that before February 1st. On remote physiologic monitoring, CMS made several clarifications. They said that going forward, RPM codes will continue to be able to be covered for patients who have acute as well as chronic conditions. They also clarified, as the AMA had recommended, that the 20 minutes of time that's required to code 99457 and 99458, 2 of the RPM codes, can include time furnishing treatment management services as well as interactive communication with the patient. RPM for new and established patients is only going to be allowed for the duration of the public health emergency. Afterwards, RPM will only be covered for established patients. And at the end of the PHE, other RPM flexibilities are also going to end. So the services will need to include at least 16 days of data collection in each 30-day period for which they're used. They also finalized some policies for the Medicare Diabetes Prevention Program. This is one of the more confusing parts of that final rule, I would say. These new policies are going to apply for not for the future, but for future declared public health emergencies. So if that could be future nationwide emergencies. Hopefully we won't have another epidemic like this, but if we did, it would apply. But also for more localized outbreaks or natural disasters such as hurricanes or whatever that might occur in particular states. So for these future public health emergencies, only diabetes prevention program suppliers who are qualified to provide in-person services will be able to serve as Medicare diabetes prevention suppliers. They will not allow virtual only suppliers to enroll as Medicare suppliers, but they will allow patients who are receiving Medicare DPP services virtually due to the public health emergency event to continue receiving all of their services virtually, even after the emergency has concluded. They'll also continue to relax the once per lifetime limit to some degree for patients who participate in MDPP, but experience one of these public health emergencies. And they're adding virtual weight measurement methods that will not require people to come in person to a program in order to have their weight measured. So, Kim.
Thanks, Sandy. Next slide, please. So looking ahead, we realized at the state level, we're really at a critical moment. There's lots of attention on telehealth within state policy circles. The National Governors Association just in November issued a report on state health policy on telehealth, and COILA is considering a draft model bill on telehealth right now. And just at our State Advocacy Summit, which was last week, we had a panel on telehealth, but we also had a panel with regulators and another panel with legislators. And I can tell you that during both of those panels, both the regulators and the legislators talked about telehealth as a priority for them. It is something that we anticipate many states addressing because, again, many of these legislators were not in session when the pandemic hit. So this is their first opportunity can make many of the policies, the temporary policies that were put in place through executive orders or insurance directives, permanent. And I think we really have an opportunity to collectively work together to support and maintain those policies that promote sustainable adoption of high quality coordinated telehealth. So what are some of those policies? I think first and foremost, telehealth needs to be looked at, and I talk about this all the time when I speak before NCOIL or others. It has to be integrated seamlessly into the delivery of healthcare. It's just one of the ways in which physicians and other healthcare professionals can provide care to their patients. Just one tool in their toolbox. Broadly speaking, digital health, including telehealth and remote physiological monitoring, can really allow us to move to this hybrid model of care. And we need to support and advance policies that support physicians to provide this care. So I think one way is looking at, I think is a no-brainer, right? And that's coverage. We need to make sure that there's coverage parity. And again, this should be a no-brainer. We need to eliminate barriers that exist to accessing telehealth, whether it be originating site restrictions or geographic restrictions, or restrictions on limiting telehealth to certain types of services. For example, only mental health services, only behavioral health services, only certain types of services. We need to make sure that it is available to patients and physicians based on what the patient and the physician believes is appropriate. We're hovering right now at just around 30 states that have coverage parity laws in place for state regulated plans. A couple states I would point out too with strong coverage parity laws, California, Delaware, Oklahoma, Texas. I would also add in Vermont and Virginia as some others. So if you're interested in looking at what some other states have done, I would point to those. Second, we believe that high quality coordinated telehealth combined with in-person visits has the potential to improve patient outcomes and reduce overall costs. Therefore, it's really important to make sure that policies are in place that promote both the patient-physician relationship and the continuity of care. For example, as I mentioned earlier, prior to the pandemic, we saw some insurers establishing separate telehealth networks that relied on direct-to-consumer telehealth companies like Amwell or Teladoc, and didn't always include those contracted physicians. We need to make sure that that does not continue. We've seen widespread adoption of telehealth. It's more likely to be available from a patient's in-person, physician that they see on a regular basis. So we need to, first off, require that all insurers allow all contracted physicians or in-network physicians to provide care via telehealth. We need to eliminate separate telehealth networks. The AMA has a model bill on this. California has some good language. There's some good language in a Massachusetts bill that was just signed into law by Governor Baker on January 1st. And then we also need to prohibit plans from using telehealth providers to meet network adequacy requirements. And again, I would point to that recent legislation passed by Massachusetts as some language for that. Next slide, please. Along those same lines, we need to talk about cost sharing. And cost sharing should not be used to incent care away from certain providers, including the regular in-person physician. It should not vary based on the telehealth provider. And reducing cost sharing for select telehealth providers who do not also provide in-person care inappropriately steers patients away or incentivizes them away from the regular in-person physician, and this disrupts the continuity of care. It's also confusing for patients. Keeping in mind that telehealth must be a supplement to and not a replacement for in-person care, I think it really helps make this policy make sense. And then finally, fair payment. We need to ensure fair payment to support advancements in telehealth. We do believe that there are benefits and potential cost savings to telehealth services, but those cost savings should not come from payment reductions to physicians who are simultaneously investing in telehealth expansion. As stakeholders promote and expand telehealth services, we need to make sure that payment is commensurate with those services. Some states I would point to for good language, California again, Delaware, Georgia, Kentucky, and Washington. Tennessee and Massachusetts have some language as well, but it's time limited to 2 years, and which might not but necessarily be a bad thing. We're in the process of doing a lot of data gathering on this issue. And we may not have all the answers at this moment, but we will make sure that policies that we have are supported and grounded in that evidence. Payment is one of these areas where we're hoping to learn a little bit more. Next slide, please. The other areas that we'll continue to work on is supporting and advocating for equitable access to telehealth, both in expanding the definition of telehealth to include audio only, which is a shift from policy that we had pre-pandemic, and promoting digital literacy, and of course, expanding broadband access and internet access, across the country. Finally, the AMA has, and we can, one more thing, a patient-physician relationship, longstanding policy that we have language in our model bill addressing this. Patient-physician relationship can be established via telehealth if it meets the standard of care. And finally, the AMA has and will continue to support state-based licensure and the Interstate Medical Licensure Compact as a mechanism for physicians who want to be able to practice across state lines. And really, when it comes down to it, this is really about protecting the safety of patients and protecting the public, ensuring that physicians and other healthcare professionals are licensed in the state where the patient is located, ensures both that the patient is, that physician or healthcare professional, if something goes wrong, that they, that the state licensing board has oversight over them, but it also ensures that state practice acts, informed consent laws, and scope of practice laws apply, and also that the state liability laws apply as well. So really important to maintain that state-based licensure. Slide, please. And then this is just a list of some of the resources that the Advocacy Resource Center has put together on telehealth. Welcome, if any of these are interest to you, reaching out. Some are COVID specific, some are summary of state. Our most recent issue brief kind of lays out the policies that I just talked about in greater detail. We also have just finished a state law summary, a 50 state law summary, providing kind of where we are at in terms of telehealth laws across the state. I mentioned we have model state legislation, and then as part of our continued work, we work really closely with the state medical associations across the country, and couldn't do what we do without them on the ground advocating for these policies. But we also work with state-based policy organizations that are national, like the National Governors Association, like NAIC, like NCOIL. And I mentioned NCOIL has a model telehealth bill that's going through their committees right now, and that they're considering language on that right now. So that is ongoing, and we'll continue to work in this space to make sure that the policies that protect physicians are in place. Next slide, please.
Okay, thank you, Kim. So the recent CMS final rule really only begins to set out a policy direction for Medicare telehealth coverage beyond COVID-19. Many people have said that they cannot imagine things going back to the way they were before and having all the barriers to widespread telehealth coverage and financial sustainability being reimposed. But in spite of that, there are a number of challenges that we will need to address in order to preserve and improve the landscape for telehealth coverage in the future. The adoption of telehealth happened so quickly that there's not really very good understanding at this point of how it's being used in patient care, what it costs to provide, and how it affects quality and health outcomes. So there's a continuing need for more information on telehealth use cases, quality, and cost. Some policymakers already have raised questions about telehealth overutilization or abuse. Questions have also arisen about whether telehealth services should continue to be paid the same as in-person services. The AMA has been conducting some research on the return on health of using telehealth, or how it impacts patients' health. And it's really important not to lose the many advantages of continuing coverage of telehealth services beyond this coronavirus pandemic. It's a huge advantage for patients who have mobility problems, those who lack transportation access or live far from their physician's office. All of these are barriers to timely care. It can be a major advantage in situations in which travel is dangerous or infeasible, such as severe weather or natural disasters, in addition to epidemics. It's preferable in situations in which in-person visits can carry health risks for patients, such as when they have communicable diseases or patients who are immunocompromised. Next slide, please. It's also advantageous for patients who may be reluctant to seek in-person care, such as those getting behavioral health services, addiction treatment, etc. And there are some patients who have sporadic symptoms, where telehealth allows the physician to see the patient at the particular moment when those symptoms are occurring. For some conditions, we've heard from physicians that they can better manage their patient's treatment when they can see their patient's living environment. Can enable more coordinated care by allowing 2 or more physicians, such as a primary care physician and a specialist, who are located in different places, to be included with the patient in their visit at the same time. Can also allow family members, caregivers, or a friend to also participate in a visit along with the patient without their having to be physically present. So this is contact information for Kim and me if you'd like to get a hold of us with questions afterwards or to access some of our resources. And with this, I think we'll turn it back to Brittany.
Thank you so much, Sandy and Kim. After these next few slides, we will transition to the Q&A. For additional resources to support your physicians and care teams during this time, please visit the American Medical Association website. We thank you for your time today and hope that you're able to join our next scheduled webinar on Tuesday, January 19th at 1 p.m. Central Time, which will feature Dr. Marie Brown, who will present on vaccinations, roadmap for success. I know Kim and Sandy kindly offered their contact information, but we also encourage you to contact the Action Labs inbox with questions, comments, concerns. That email is action.labs@ama-assn.org. Finally, after concluding this webinar, you will have the opportunity to participate in a brief 4-question survey. We ask participants to please take 2 minutes to fill out the survey. Your feedback is important to us as we continue to develop future programming. Now we're going to go ahead and jump into the Q&A. Please give us a moment to get our camera set up here. I'm back. Hello. All right, so if any of our attendees would like to elaborate on a question, or if you have a follow-up question that you would like to articulate verbally, we encourage you to use the raise your hand function and we can unmute you. Kim and Sandy, I will be reading the questions off to you. I can see that we already have several in the queue, so let's go ahead and get started. So for this first question, this participant would like to know if you have any insight or information on other states that continue to lack infrastructure for telehealth in rural areas. This participant is in Oregon and things are not moving forward for this support with any urgency.
Yeah, it's a really good question. I think that, again, this is on the radar of state level policymakers. I know it was addressed in the National Governors Association report. So definitely on the radar, but of course, when we're talking about infrastructure, it's not something that's going to be able to happen, quickly, unfortunately. But do, continue to support kind of these discussions and making sure that we bring this to the top of mind of legislators and regulators and governors really across the states.
Thank you. This participant would like a little bit of clarification. They would like to know if telehealth is covered from December 21st or covered until 12/21 or 4/21. So I'm assuming December of 2021 or April of 2021.
It varies. So first of all, the most recent, this public health emergency declaration has to be extended every 90 days. So the most recent extension takes it to about April 20th or 21st of 2021, but it definitely could be further extended. And it's certainly possible that this PHE is going to go itself all the way through the end of 2021. We just don't know. But, you know, we're having record numbers of cases, of deaths even now. So it unfortunately doesn't seem like we're near the end at this point. CMS has classified services that it's covering via telehealth in multiple ways. So some are covered permanently. They've been permanently added to the Medicare telehealth list. Others are the ones that are in this category 3 are going to be covered until the end of the year in which the public health emergency ends, which would be December 31st of 2021 if it ends this year, anytime this year. Others are only going to be covered for the duration of the public health emergency. So if it's not extended and it ends in April, then the coverage of those services would end in April. Importantly, the lifting of the geographic and originating site waivers is linked to the public health emergency. CMS does not feel it has the ability to extend that waiver beyond the public health emergency. So if the PHE is not extended, then the availability of Medicare services via telehealth, if there's no action by Congress, and if there's no extension by the Secretary, would end in April of 2021.
Thank you. So this next question asks, what kind of evidence is still needed to ensure telehealth coverage and equitable and fair payment remains in place after the public health emergency?
Well, we probably both have some thoughts on that, but I'll take a first crack. We really need to know, and I got at this a little bit at the end of the presentation, we really need to know how telehealth is being used in patient care and what impact it has on healthcare spending. Because lots of people in Congress would like to see the geographic and originating site waivers continued or abandoned altogether, but they worry about the cost of doing that. So if we can get information that shows, for example, if emergency physicians are following up with patients they've seen in the emergency department within a few days of their visit, does that lessen the likelihood that those patients are going to be coming back to the emergency department within the same month? Because that frequently happens. There's a lot of patients that end up coming back to emergency departments over and over. If hospitalists are following up with inpatients after they're discharged via telehealth, does that reduce rates of readmission to the hospital? So those kind of things will be really important, we think, to demonstrate that telehealth not only is great for the quality of patients' care and the continuity of their care and all the other advantages we've talked about during the presentation, but also that it can save money for the government instead of costing them more money.
Yeah, and I mean, Sandy hit on everything there. And I think, at the state level, we hear a lot from private payers about a concern of telehealth being an additional service, right? That they're now going to have to cover. So to Sandy's point that she mentioned, being able to show the value of telehealth and that it is going to, in the end, save cost. Again, it's just one way in which physicians can provide care to their patients. But in doing so, it will reduce ER visits, like Sandy said. It will improve, chronic health conditions through both telehealth, but also remote physiological monitoring. So there's lots of ways and things that we need to be looking at here to be able to demonstrate that those savings. But in many cases, it comes down to cost. So if we can show some savings there, it's going to make a tremendous difference.
Thank you both for that. In your presentation, you discussed how the AMA has supported services for audio video telehealth. Now, how is the AMA supporting continued access to telephone services for patients who don't have the technology to use audio video telehealth?
This was really a heavy lift last spring. We had so many meetings with different parts of the federal government to try to get them to start covering the audio only services. It just was not happening. And we had to push and push and push over and over and over again before they finally agreed to do that, and then had to push again for the payment rates to be increased to equal the in-person services. So we've just basically been continuing that advocacy. We've said continually to CMS that this coverage needs to remain, that there are a lot of inequities that have been exposed through the COVID pandemic, as Kim discussed, and that you'll be cutting off this service for a lot of people if they stop covering the audio only services. So it's just basically a matter of continued advocacy, pushing again and again.
Yeah.
Yeah, and likewise at the state level, just that continued advocacy. And I think, as I mentioned in the presentation, this is a little bit of a shift in where we were prior to the pandemic. But I think hearing loud and clear from physicians that this is really important and necessary for them to be able to, and for their patients to be able to utilize telehealth. So we'll just continue to support that at the state level as well.
And I think, all of us have experienced this issue, whether or not you've experienced in a telemedicine visit yourself, where there's suddenly a technology failure, or maybe a technology failure from the very get-go, and your only option is to do that by telephone. But we've certainly all seen it with all the Zooming and Teams and all the other things we've been doing online during the pandemic. I mean, the inability to use the technology that's needed, or the failure of communication, your Wi-Fi fails, whatever it is, there's just a million different reasons why things go wrong. And you can't depend on it. You got to have that backup, which in the case of Medicare telehealth services is audio only visits.
So going back to telehealth at the state level, what are some examples or models of successful telehealth policy at the state level?
I would point to a couple states. California has a really good law that actually was enacted in 2019 and signed into law by Governor Newsom back then, but wasn't effective until January 1st of this year. So interestingly, during the public health emergency, Governor Newsom actually had to adopt an executive order putting in place all of the policies that they had already enacted in legislation, but just was not effective yet. Other states I would point to: Delaware, Georgia, Washington, and Kentucky, to name a few. And I think, and Virginia is another state. I think that many of these states have, kind of the sweet spot of the important provisions in place that I talked about, from coverage parity to fair payment to making sure that contracted physicians are able to provide telehealth to their patients. And I think that having, those policies in place are kind of the bare bones minimum at this time, that we think, let's make sure we have this in place to make sure that we can continue forward in supporting high quality telehealth.
Thank you, Kim. So for this next question, this participant asks if there are any changes to med malpractice coverage using telehealth across state lines.
Yeah, I mean, that's a question. We really have encouraged physicians to reach out to their liability carrier to make sure first that they're covered for telehealth, right? Make sure that their liability carrier is covering them for telehealth services. And likewise, if that physician wants to be able to practice across state lines, making sure that that is covered by their liability carrier. But that really is a carrier by carrier, physician to physician, needs to be done at that level.
Okay. So this next question states that this participant believes that an obstacle to telehealth is the credentialing of doctors by private insurers. In other words, you might seek telehealth services from a doctor who is out of state and not in your PPO network. They would like to know if this is something that we can work on changing.
Yeah, that kind of goes along the same lines of the licensure issue, right? And what mechanisms are in place to have processes in place for other healthcare hospitals and other healthcare entities to recognize credentialing from other healthcare services. So I think, something certainly, we can look into and willing to work on, and how that might, become part of our broader telehealth policies.
Okay. And do you envision changes with how licensure is handled for telehealth? If so, do you have any examples of what that could look like?
So again, the AMA continues to support state-based licensure. There are probably, and again, I think one of the reasons why we haven't, we have to recognize that during the public health emergency, almost every state took some action to allow physicians to either practice across state lines or create some sort of mechanism where physicians could register with the state to be licensed in that state for that interim period to provide telehealth services. There may be some areas, right, where maybe a physician who lives on a border state that has some patients, I live in the Chicago area. A physician who practices in Chicago has patients coming from Indiana. Maybe, there's some mechanisms there to allow cross-state licensure for kind of these, states that are kind of in the same region. And I think that there might be some kind of, we talk about snowbirds or college students who might be temporarily out of a state. Maybe there's we can have some conversations there. But this needs to really be done within the structure of state-based licensure. Again, as I go back and talking about really the importance, we have to remember that the state-based licensure is there to protect the public and ensure that the public is protected if something goes wrong. And so I think we just really have to keep that in mind, as well as the importance of maintaining state practice laws. State, whether it is the age of consent, you've got abortion laws, you've got scope of practice laws, a number of state laws that we need to make sure stay in place and are stay in place for the state in which the patient is located.
Okay. And I think you touched on that in your response. And I will note that we are almost at the top of the hour. So this is the last question that I'm going to read off. This participant would like to know if there's a college student that is quarantined out of state, is there any room for them to see them if they're practicing in another state, that they're not, if they're in another state and they're not licensed in the particular state that that college student may be in, if they are not able to see them, would that be considered abandonment?
I'm not sure about that, but I would encourage them to go to the Federation of State Medical Boards. Has done an excellent job of keeping up to date on what those waivers are in state licensure laws for telehealth. So if you go to their website very quickly, they have COVID-19 resources, and they have a chart that is updated on a weekly basis. So I would suggest that they go there, look at the state that the college student is located in, the state where the physician is located, and see if they can figure out from there. And then always double check with the state licensing board, just to make sure.
Thank you, Kim. And I do see that we do have a couple of comments in here and several other questions. I do encourage you all to reach out to the Action Labs inbox with any follow-up questions that you may have. We're happy to help provide responses if we are able to. We're also happy to direct you to any resources that were mentioned during this webinar. You will have access to the full recorded webinar after this event, along with specific resources from the PowerPoint slides. With that said, I would like to thank you, Kim and Sandy, for all of your time and expertise today. To all of our participants, thank you so much for joining us. We hope to see you again soon in another upcoming webinar.